And welcome to the Dr. Bob Show. I never realized that so many people had shoulder problems. At any age, it can be young people, it can be middle-aged, it can be older, it can be a joint injury, it can be tears, it can be arthritis, and there are cures for all. My guest is Dr. Ed Spencer. Dr. Spencer is a board-certified orthopedic surgeon who deals just with shoulder injuries, and he'll be answering our questions. Hello, I'm Dr. Robert Overholt, and I'll be your host for the next 30 minutes on the Dr. Bob Show. Later on, we'll be talking about a crooked nose. Does it need to be fixed? Is it just cosmetic? You'll be surprised at the answer. And rectal bleeding. Is it always abnormal? Yes. Does it always need to be fixed? Maybe not, but it could be an underlying cancer. A lot of information for you. You'll want to stay tuned. We're talking with Dr. Ed Spencer, board-certified orthopedic surgeon. We're going to be talking about shoulder problems, and Dr. Spencer specializes in shoulder problems. Ed, welcome to the Dr. Bob Show.
Thanks for having me.
So tell me, why do so many people at so many different ages have shoulder problems?
Well, to start out with, the shoulder is the most mobile joint in the body. So as a youngster, you're more prone to injuries like instability. But then even as we get older, with your hand being the most useful instrument that you have, your shoulder is what's going to place it in space. And so with time, with more overhead activities, we can develop things like rotator cuff tears and even arthritis.
So there's a wide range of ages with those. Let's talk about younger people.
Right.
Why and what type of shoulder problems do they have? And by young, let's say when you start sports, or you're in high school, or you're in college.
Yeah, it's a good time to talk about that because it's football season before we know it's going to be spring training. And so a lot of us love taking care of the throwing athlete. And again, it's not only the throwing athletes, it's the contact athletes, to include football, lacrosse, I mean, any of those contact sports. Even basketball can be considered a contact sport. The shoulder is a big ball that sits on a very small cup, and as such you rely on the ligaments and you rely on something called the labrum, which is kind of like the cartilage that's on the tip of your nose. It's sort of a fibrocartilaginous ring that helps maintain the stability of the shoulder. When you dislocate, you can tear that cartilage ring and you can stretch out those ligaments, and sometimes that can be treated non-operatively. Sometimes we have to go in and repair it, and we can repair it arthroscopically and get the vast majority of these patients back to playing the sport they want.
So that's what we call a labrum tear. So it's a cartilaginous, and you can rip it or tear it with stress or throwing or almost anything?
Yeah, sometimes it's a traumatic dislocation. You'll see many times a football player dislocate their shoulder on the field making a tackle or hitting the ground. But sometimes it's through repetition. So our throwing athletes, like our pitchers, just through repetition can tear their labrum and even stretch out their capsule in various ways that will need to be many times just rehabbed, but sometimes repaired.
So how do you repair that?
Most of that is done all arthroscopically, which is just a couple small poke holes in and around the shoulder in order to get down in there, infuse the shoulder with some fluid so we can distend it and look at the shoulder, and then we're able to take small instruments and manipulate that tissue and then place anchors in various positions, and those anchors usually have suture attached to them, and then we can pass that suture and repair that tissue back down to its native state.
I just sit there in amazement because you do that through a couple of little holes,
right,
and you put some fluid in there to open up the area, and then you can see in there with cameras, I guess?
Yes, yeah, we use cameras, and then again, it's really small cannulas and instruments that we can get in there to do this work, so we don't have to make big incisions and cause sometimes more of a problem. We can get in there and just address the problem in a stealth-like fashion.
So is that going to be more problems in a baseball pitcher that throws, or more problem in a football player that gets his shoulder caught in an injury? It could be almost anything.
Yeah, it depends. The sport really dictates the pathology or the problem. So we see just as many baseball players as we probably do football players when we're talking about injuries in younger patients.
So if somebody has a labrum tear and you fix it arthroscopically, does that mean probably they're going to end up having some problems later on, or not necessarily so? You fix it and it's fixed.
Not necessarily so. With the dislocations, we know that long-term studies that a lot of these patients, when they dislocate their shoulder, or sometimes even when they tear their ACL and injure some of the cartilage in the knee, you start seeing patients like my age now, all right? So you had an injury when you were younger, now you're a guy that's a little bit older, now you're starting to see the arthritic problems occur.
So can you prepare a person? Can you say, hey, we can fix it now, you'll probably have problems later on, or can you keep them from having problems later on?
Well, if you stabilize the joint, the chance of them having problems on down the line is less. But if I tell an 18-year-old patient, hey, you're probably going to develop arthritis when you're in your mid-40s, you know what he's going to say? I don't care. Fix me and get me back on the field.
Get me on the field.
Right.
So as we get older, the problems that we get when we get to be 30 and 40 and 50, what are the problems you have there? Do you get labrum tears then, or you start thinking about other problems?
Yeah, it's not as much labral pathology at that point. You can get those, but those are usually degenerative tears, kind of just getting a little bit older. What we typically see in our middle-aged patients is rotator cuff tears, because the rotator cuff tendon is there's 4 muscles that make up the rotator cuff tendon structure, if you will, and its job is to hold the ball in the socket.
So they let you move it around, but doesn't let the shoulder get out of the socket. That's the rotator cuff.
That's the rotator cuff. It essentially holds the ball in the socket so your bigger muscles can cause the shoulder to move. And over time, especially with more overhead activities, with more vigorous activities, those tendons can become torn, and specifically the ones up top.
So do they tear incompletely? Are they tears all the way through? Or you've got to get special x-rays, or your exam can tell you? How do you know how bad the tear is?
Many times it's your exam. And so for people listening out there, most of the time if you've got a significant rotator cuff tear, you've got a mechanical problem raising the arm, or you can't raise the arm at all. So some rotator cuff tears are large traumatic tears. You see people that fall down from an elevated position, they fall from a ladder. That's very frequent. The other thing is the repetitive stuff up overhead. So there's some specific occupations like mail carriers. You're always casing mail, doing stuff up top like that. They'll get partial rotator cuff tears that then get a little bit bigger, then get a little bigger. It's kind of like having a tear in your jeans, and you continue to wash it, and that tear gets a little bit bigger, and it gets a little less distinct.
So if you've got that tendon in a rotator muscle that you're repairing, is the repair always surgical with sutures? How difficult is that? How do you repair it?
That's a great question, because that's actively changing. Most full thickness rotator cuff tears will fix. We'll repair the tendon directly to the bone. And again, we do that arthroscopically, which is a great benefit for the patient because there's less scarring. And I think the healing is just as reproducible when you're doing an arthroscopic cuff repair, if not better. But there are some partial rotator cuff tears that we can do something called PRP. It's called platelet-rich plasma.
Platelet-rich plasma, PRP.
Right. And we're just trying to figure out where we can apply this technology. What PRP is, it's your own blood that's centrifuged down to concentrate platelets, and with those platelets are going to be growth factors. And so it's a totally different injection than a cortisone injection. Cortisone is just an anti-inflammatory. Great for bursitis, great for inflammation. It's not going to help you build anything. It's not going to repair anything. PRP actually has the capability of enhancing healing. So we know that if we place that PRP when we're doing a cuff repair, it really doesn't change anything. But we've done several patients now, quite a few patients, where we just inject the PRP with ultrasound into the tear, into the partial tear, and have had some really good results. And so that's emerging. We're following that along. That's newer technology.
So if there's requirement of surgery, is the surgery for rotator cuff successful?
Yes, it's one of the most successful surgeries that we do.
That's what we're going to be talking about when we come back. Why is the surgery for rotator cuff so successful, and does it remain that way? And then later on, as we get older, what happens to the shoulder, and what do we need to do to help that? A lot of information for you. You're going to want to stay tuned. We're talking with Dr. Ed Spencer, board certified orthopedic surgeon, deals with shoulder problems. We've talked about an unstable shoulder. We've talked about labrum tears. We've talked about arthroscopic surgery. We've talked about, not in the old days where we had the big scars, and now we've gone into rotator cuff where there's a tear of tendons that are there, or the tendon gets fragile and we've got to go in arthroscopically again and repair that. So Ed, you mentioned that the recovery time and the recovery and the success of rotator cuff is pretty good.
Yeah, rotator cuff repairs, especially now that we're doing them arthroscopically, the results are amazing. They really are amazing. So we can get in with just very small portals and repair the rotator cuff tissue back down to the bone, and there's various means of doing that, various anchors, various anchor configurations, and it allows us to more easily reconstruct the normal anatomy there. The recovery time varies based on what you have to deal with. So just like each rotator cuff tear is a little bit different, and I would manage 10 different patients with 10 different cuff tears differently. Different anchor configurations, we may do something with the biceps. It just depends on what you have. You also vary their therapy afterwards. So if we have someone that has a really large tear, tissue that may be a little weak because maybe they're a little bit older or maybe they've got some sort of autoimmune disease, you're not going to start them in therapy as quickly, right? Makes sense.
Sure.
But if you've got someone that has a smaller tear, a younger patient, you're going to start them in therapy more quickly because the construct that you achieve with a patient with a smaller tear, good bone, good tendon tissue, is going to be so much better than someone that's got a massive cuff tear that's got weaker tendon tissue. So you got to treat them differently. You got to be cognizant of that.
You know, the thing that I liked about what you said is every patient is different. There's no cookie cutter approach, and you've got to treat every patient according to really what happened to them.
Right.
As a person gets older and we get arthritic changes and somebody can't put their hands above their head and they've got limitation, what's going on there and what's the answer?
Well, many times it's bone-on-bone arthritis, and so that can happen in any joint.
So normally there's cartilage that's in the joint that's helping people, and bursa, there's different areas where the shoulder is easily lubricated. So
Right.
then that goes away and you get bone on bone. You don't get anything to protect.
Right. So when you lose that nice, smooth cartilage that's on the end of the bone that provides all the cushion, then all the load gets transferred to the bone, and the bone starts developing these bone spurs. It starts getting wider and developing these spurs to try to increase the surface area to distribute that load. So the body's just trying to accommodate for that increased load that it's seeing. The problem is those bone spurs then decrease the range of motion. You can't reach up overhead, and it hurts. And people are living longer and longer these days, and they're wanting to do more and more. I mean, we see plenty of patients that are in their 60s and 70s. They're hiking mountains, they're kayaking, they're doing all kinds of stuff. It's not, they're not sitting in rocking chairs. So we need to get them back to doing that. I mean, I guess 70 is the new 50, right? I mean, they're wanting to get out there and be athletes.
When I grew up, people died at 65. Now they're dying at 86. By the time I get to be 86, it'll probably be 92. So I want you keeping me where I can run and wiggle a lot. So the shoulder's a big part of our activity when we're grabbing and when we're pulling. Right. So with arthritis, what can you do for it?
So we do a replacement, and replacements have evolved just like in the shoulder, like they've evolved everywhere else. One of the things that's really evolved in shoulder replacement is the stem size. All right, so we used to use.
What do you mean by stem?
So we used to use these longer stems that go down the bone, and many people are familiar with stems like with hip replacements. It goes down the bone, and then the ball sits on top of that. As we have evolved, we've made that stem shorter and shorter, and we've actually developed stemless replacements that remove less bone and are actually more accurately done so that we can reconstruct their normal anatomy, what was there before the arthritis, much more accurately with a stemless design.
So stemless design, stemless, no stems at all, is sort of new to me. I thought you always had to brace it with a stem, and then, so show me what you're talking about.
So this is a stemless component here. So no longer do we have a stem that goes down the end of the bone here. We've got this, and it looks almost like a Mercedes-Benz sign, and It's got a lot of grit on the back side of that. and that gets pressed down into the bone here. And that we've done a long-standing FDA study that shows that the fixation here is just as good, and we don't have to go down the bone. And then once that's pressed in there, then all you have to do is put the head on top and you're done.
Wow.
So it's much quicker in the OR, and there's less blood loss. And so it really has been a significant advantage.
So have they been doing these for a long time? Have they been doing them in Europe and the United States? What's the experience?
When we first designed this implant, we couldn't use them here in the United States until we had FDA approval, and that required an IDE study, which is a study where we have to have multiple centers around the country put them in, and then we watch them for 2 years, and then we watch those results. So after the first one's put in, it's 4 years before we can introduce it to the U.S. for public consumption. However, in Europe, we were able to put in, or they were able to put in thousands before we were able to put any in. Right now, there's probably been maybe 5,000 to 6,000 of these put in, maybe a little bit more. I don't want to overestimate it, but it's certainly at least 5,000 or 6,000 that we've put in, and we've had fantastic results.
So this is the newest and the greatest. Do you have to do that with a big incision? How do you do that one?
Well, yeah, this is done with an incision. So the incision really doesn't change with the length of the prosthesis or the materials properties of the prosthesis. We still make an incision that's on the front of the shoulder, something like this, and that allows us to get in there and open the shoulder up like a book, do the replacement, and then close it back. And then there's rehab time and downtime, about 6 weeks, where we say don't reach up over your head like this, but you're going to be able to do countertop level activities. You can type, you can write, you can use a computer. You could use a computer that night, as a matter of fact. So we put anesthetic in the shoulder when we get done, and then that night people are able to take the sling off and actually use a computer if they want, or use it to eat with.
So this is the newest. It's easier. You don't have a stem. The recovery time is obviously much quicker. When can you go hiking and pulling up on something and reaching up on a ladder and doing the things that we want our shoulders to do?
About 3 or 4 months out. So the first 6 weeks we're letting everything heal, and then we work on strengthening exercises for a second 6 to 8 weeks. That's kind of like the second phase. By 3 or 4 months, I'm letting them play golf, letting them swim. You'll still get improvements in your function, in your range of motion, in the things you want to do for at least a year, in some studies even 2 years.
What's a reverse shoulder replacement? Are you still doing those?
Yes, sir. Great question. And reverse shoulder replacement, we can look at that model in a second, is simply this. Instead of the ball being on the ball side of the joint, the ball now gets screwed onto the cup side of the joint. And the reason we do that, so obviously the cup then is on the ball side of the joint. And
so
maybe
you just reverse those.
You just reverse those. And so simply we do this when someone has a arthritic condition, but unfortunately doesn't have a rotator cuff that is sufficient to support the prosthesis, or has bone loss. And so this is the way that it looks. The ball here is on the shoulder blade, and this is the cup that's on a little stem that sits down in the humerus, and it rotates like this.
So the stem usually has the ball, and you just put the ball in where the socket was.
Exactly.
And just reverse them.
Right.
Why do you do that?
Because there are some cases of arthritis where the rotator cuff is not functional. And if the rotator cuff is not functional and you put in a regular replacement, it won't work. It'll ride up. And so this is a semi-constrained design where it can't ride up, and it gives the deltoid muscle, this big muscle on the outside, the ability to reach up and do things. There are other indications, but I tell you what the interesting thing is. This design started back in the 50s. People had ideas like this back in the 50s, but we really didn't have a really good design that would be good for public consumption until 2004, when it was introduced in the United States.
So you've got several options when you've got a bad shoulder of shoulder replacement. I want to talk about one other thing. And if somebody has a fracture of the top part of the arm in the shoulder area, what is this?
Yeah. This is an exciting new product. This actually will get reduced down to 8 millimeters, but this is an expandable cage that we use to support bone from below. The shoulder in particular, as we get older, the bone in the middle of the ball gets really deficient. And when we fracture and we try to fix that with screws, the whole thing can collapse. And if that happens, the screws penetrate and you get arthritis. So many times we got to put bone graft in there. Well, the bone graft can dissolve. This is a cage that is, you can squeeze it, but it'll support the bone from below, so we can open up the bone and we can put screws right through this and fix a fracture. And the interesting thing about this is bone grows through it.
Wow.
Yeah, it's made out of nitinol.
You know, actually, somebody in my family had that done, and their recovery is unbelievably good. So I want to show that X-ray on the Dr. Bob show here. Ed Spencer, you're a great teacher. You've shown us new things that I didn't even know were available, and the new shoulder replacements are getting so much better and so good. And we can fix the unstable shoulder. We can fix the rotator cuff. You all are amazing, and I want to thank you for your expertise, and you're looking into the future where we can get better and better with every patient and every year.
Thank you, Bob. I appreciate you being on the show, man. Appreciate being here.
Absolutely fabulous. You're going to want to stay tuned. We're going to be talking about a crooked nose. Is it really just a cosmetic thing, or can it improve your health? And rectal bleeding, bleeding from the rectum, is it always abnormal? We call it hematochezia, to use big words, but it can be due to bad things and it can be due to not so bad things. A lot of information for you. You're going to want to stay tuned. I want to thank Dr. Ed Spencer. Wonderful discussion on shoulder problems ending up in shoulder replacement. I hope you enjoyed it as much as I did. And now questions from you, the viewer, that I think will be important to your health. Question number one, Dr. Bob, I have a crooked nose. Does it need to be fixed? Well, the septum is the midline of the nose. We can get septal deviation. If you can breathe through your nose, we used to say it's okay, you don't need to get it fixed. But let's talk about the inside of the nose. There are three mountains called turbinates. They're balls, and air comes over those and grabs up warmth and moisture. So if you've got a crooked nose, the air doesn't go through one side, and so the turbinates on the other side get larger so that they'll grab up warmth and moisture for the lungs. Eventually they get bigger and bigger where you can't breathe through either side, you get a stuffy nose. Now the airflow with a crooked nose also can create some sinus disease, and sinus disease can feed the lungs if you've got lung problems. So more and more I'm beginning to think that a crooked nose is just not a cosmetic problem, but needs to be corrected. If you've got a crooked nose, talk to your doctor about it. See an ear, nose, and throat specialist, somebody that can fix that nose properly so that you can breathe again. That's called septoplasty. Question number two, Dr. Bob, I've got rectal bleeding. Is it abnormal? Does it need to be fixed? Well, anytime there's bleeding from the rectum, it's abnormal. But it could be a fissure, a little tear that bleeds. That will be fixed automatically by itself. There could be hemorrhoids that need to be fixed. If you've got hemorrhoids, it could be that something has made you strain, like maybe some obstruction or too much constipation or maybe childbirth. So hemorrhoids are very, very common. There's new ways to fix hemorrhoids. But let's look at other problems that cause rectal bleeding. It could be diverticulitis. That's inflammation of the lower part of the colon, and that inflammation can cause redness and bleeding and inflammation and cramping and red bloody stools. If you've got a polyp in the colon, those can cause bleeding, especially if they go to cancer. That's why it's so important to have a colonoscopy at age 50 or younger if you've got colon problems in your family history. If somebody has Crohn's disease or ulcerative colitis, they frequently will have bleeding in the stool. So there's lots of things that can cause bleeding of the stool. If you have bleeding in your stool, you should talk to your doctor about it. Don't worry about, the rectal area is very, very sensitive and I don't want to talk to my doctor about that. Well, you need to talk to him about it. You'll probably want to do an examination, a colonoscopy to see why the bleeding's there, and then get it fixed. And then you don't have to worry about that problem. So if you've got rectal bleeding, talk to your doctor about seeing a gastroenterologist, having a colonoscopy, and with the colonoscopy finding out what the problem is. It's all the time that we have for this show. Remember those 4 things. Exercising, probably the most important thing we can do. And we can do it at any age. And it doesn't have to be running and jogging. It can simply be getting your tennis shoes out and going for a walk on a regular basis. It needs to be 30 minutes to 60 minutes, 5 days a week. You'll find that it makes you feel better, lowers your blood pressure, and you'll just feel better, no stress. Sleep 7.5 hours. If you're not sleeping well, you need to find out, you need to know why you're not sleeping well, and you need to be sure that you cut down all extraneous noises and that your bedroom is for sleeping and for sex and for not studying and not for looking at your iPad and reading books. Be sure you're eating properly. We're learning more and more that multiple small meals are better if you need to lose weight. You've got to fuel the engine, so fuel it with food. And most of all, what is it we like in that Dr. Bob show? It's that laughter in your life. If you'll giggle, if you'll have fun with people and laugh a lot, you'll find that you'll be healthier.